Good morning, everybody. My name is Max Vest. I'm the hand surgery fellow at Virginia Tech Curling Clinic, Orthopedics. This topic's on distal radius fractures. First, I want to start with the anatomy of distal radius fractures. The distal radius articulates with the proximal carpal row, and it serves as the origin of the volar and the dorsal wrist ligaments. There are three articular surfaces in the distal radius: the scaphoid fossa, which is right here and supports the scaphoid, the lunate fossa right here, which supports the lunate and the remainder of the carpus, and then the sigmoid notch, which is right here, the articulation with the DRUJ, and also the insertion point of the TFCC. There are many unique curvatures of the distal radius, and these are all important to take into account when treating these fractures. And another important landmark in the distal radius we use is Lister's tubercle, demonstrated right here. Um, and this is well known to separate the second and the third dorsal compartments. Um, there's different ways to think about the distal radius and fractures, but a simple way to think about these fractures, particularly when treating them, is to think about a column approach. And there's three main columns you want to think of. And the first is the radial column, which includes the radiostyloid and the scaphoid fossa right here. And then there's the intermediate column, which involves the lunate fossa and also the sigmoid notch and the articulation with the DRUJ. And the third is the ulnar column, which is where the TFCC is and the distal ulna. And it'll come up when you're treating these fractures. You can strategically fix one column first and then build off that fixated column. And we're typically fixing the intermediate column first. In terms of presentation, distal radius fracture is the most common fracture seen in the ED. These are often a fragility fracture, commonly seen in osteoporotic patients. The mechanism is often a fall on an outstretched hand, and then also patients can have high energy trauma, including motorcycles and MBCs. And like any fracture, you want to evaluate for open injuries, and you want to rule out carpal tunnel. So you want to ask if they're having any median nerve symptoms. It's present in about 5 to 8% of distal radius fractures, and reduction can help improve their carpal tunnel symptoms. So if they are having carpal tunnel symptoms, you do want to perform a reduction. And if they're not having an improvement, then you want to do a carpal tunnel release. A little bit of a historical perspective on distal radius fractures. In 1814, Colles described an improvement in function after closed reduction of distal radius fractures. And then in 1929, Volar described a pins and plaster technique, and these patients did better than closed treatment for unstable fractures. Then in 1944, Anderson O'Neill advocated distraction by external fixator augmented with bone graft. And for many years, external fixation was used to fix distal radius fractures. And then in 1951, Gartland and Worley did an outcomes assessment that showed that about 60% of these fractured collapsed to their pre-reduction state, and that holds true to today. And there's certain criteria that we'll go over that can help predict the fractures that will actually displace. So you would want to consider fixing those to prevent this late displacement and symptomatic patients. So in 1990, Geisler advocated articular reduction with percutaneous pins. 1995, Gessenway et al. Was promoting dorsal fixed angle plate fixation, which was used for a period of time. It did have some complications, including a tendon rupture. Then in 2000, Leslie and Madoff outlined principles of fragment-specific fixation. And then in the 2000s, Dr. Orbe proposed volar fixed angle plate fixation. And then as of today, probably the most common way distal radius fractures are being treated is with volar plates. A couple important radiographs you want to look at and take into account when you're treating these fractures. There's some average radiographic parameters you want to think about, and the first is their radial inclination, which is essentially the slope of the radius, which is about 23 degrees. The radial height measured from the rim of the intermediate column or the lunate fossa to the tip of the radial styloid is about 13 millimeters from here to here. And then the volar tilt, which is measured by drawing a line longitudinally with the axis of the distal radius, and then drawing another line from the dorsal and the volar surfaces of the intermediate column of the radius. And a normal volar tilt is about 11 degrees. So in terms of radiographs, you want to get good radiographs to assess the joint, and also you want to assess the different parameters we just discussed. And in terms of a PA radiograph, this is ideally obtained with the shoulder abducted 90 degrees and the elbow flexed 90 degrees to provide neutral form rotation. And this is useful to assess the radial height and the inclination. You want good lateral radiographs. You want the elbow flexed 90 degrees and adducted against the trunk with a neutral rotation. The pisiform should be midway between the distal pole of the scaphoid and the capitate head. And this is useful to assess a volar tilt. And you can also look at the teardrop angle, which is calculated by a line drawn longitudinally with the distal radius, and then another line drawn through the volar rim of the distal radius, and that's normally around 67 degrees in a normal individual. And if you have a volar rim fracture or any distal radius fracture, this will change the teardrop angle and it'll be greater than about 67 degrees. Some other radiographs that we use, particularly intraoperatively, are the extended tangential view and the dorsal skyline view demonstrated in A and B. And these can show you a couple important things, and one including you want to make sure that no screws are in the DRUJ, and you can see that here on this extended tangential view. And then you can also see dorsal penetration into the floor of the second compartment here, Lister's tubercle, and then in the third and fourth compartment here. There are many different classification systems for distal radius fractures. They're based on articular involvement, comminution, and the presence of an ulnar styloid fracture. There's the AO classification, the Fernandez classification, the Frickman classification, and the Malone classification, as well as many others. Now I just want to review a couple of the more common fracture types we see, and then we'll go over different treatment options for these. So one of the more common types of distal radius fracture we see is a Colles fracture, and this is a fracture of the metaphysis of the distal radius with apex volar angulation and with dorsal comminution, and you get what's called this dinner fork deformity, which you see here is essentially shaped like a dinner fork. There's a Smith's fracture, which is typically high energy on a flexed wrist, and you can get volar comminution, and is basically the opposite of a Colles fracture. Then there is a Barton's fracture, which is an intra-articular shear fracture. You can have a volar Barton's or a dorsal Barton's. Volar is the most common, as demonstrated in the radiographs right here, and you can see these are essentially an intra-articular split and can involve these the volar rim of the distal radius or the dorsal, as shown in the radiograph here. And there's die punch fractures, which are depression fractures of the lunate fossa, and you can get intra-articular impaction. These can sometimes be difficult to see with normal radiographs, and these might be cases that you might want to consider a CT scan if you're not sure. Then there's a Schaeffer's fracture, which is a radiostyloid fracture. This is often associated with ligamentous injuries. And you can see here, here's this radiostyloid fragment. There are a couple of the important ligaments we think about that are attached to this fragment, including the radioscapular captate and the long radial lunate. These are treated with similar principles as other forms of distal radius fractures, but you can consider fixation with a radiostyloid plate in these fractures to buttress this fragment. Then there's pediatric fractures. Without going into detail, we'll go over a couple of the common pediatric fractures, including a torus or a buccal fracture of the metaphysis, green stick fractures where there's fracture of one cortex and the second cortex still intact, and then physial fractures, which are classified based on the Salter-Harris classification. In terms of treatment guidelines, something that is important to think about is the LaFontaine criteria. And these include dorsal angulation of more than 20 degrees, dorsal comminution, intra-articular involvement, association with an ulnar styloid fracture, and age greater than 60. If more than 3 out of 5 of these criteria are met, there's a high likelihood of displacement. And this is helpful for counseling patients and deciding on treatment options in these patients. And if a patient is treated non-operatively with multiple of these criteria, it's important to obtain weekly radiographs to ensure that they don't have late displacement. And then there's the AAOS guidelines, which advocate operative treatment with radial shortening greater than 3 millimeters, dorsal tilt greater than 10 degrees, and intra-articular displacement or step off greater than 2 millimeters. I'm going to focus the rest of this talk on volar plate fixation, which is one of the more common ways we treat these fractures. And I'm going to focus on this skeletal dynamics of volar plate. And if you really understand this plate, you can get the idea of how a lot of these fixed angle volar plates work, and it can also help you understand distal radius fractures just based on the design of this plate. But essentially, you have this fixed angle volar plate. There's a fixed angle at the distal radius fragment, and then you have your distal screws, and you see these subchondral locking pegs, which are used to support the subchondral surface of the distal radius fracture. And these are nice in the case that you do have intra-articular penetration, which there's views that you can do to make sure that does not happen, but occasionally, there will be some collapse, sometimes late collapse and severely comminuted intra-articular fractures, and it's better to have a smooth peg penetrating the distal radius than it is a threaded screw. And then it also gives the option of locking compression screws. And typically locking screws do not provide compression. That is not the case with these. You can actually get about 2 millimeters of compression with these high compression locking screws, and they also have the benefit of locking into the plate. And these are useful if you want to lock in either radiostyloid fragment or maybe a dorsal ulnar fragment of a distal radius fracture. So another benefit of these plate is they, within one volar plate, they provide column-specific fixation. So they have a portion of the plate that is designed specifically for the intermediate column, and then a portion that is specifically designed for the radial column. And these are low profile distally to prevent tendon irritation. And they're particularly low profile on the radial styloid portion of the plate. And this is important because the FPL and the FDP to your index finger run right on top of the volar rim of the distal radius right here, right over the watershed line. And then there's also an optional hook plate fragment with this plate to capture this volar rim fragment. And this is an important thing to look at when you're treating these, because if there's a volar rim fragment and you miss it, then this fragment can displace volarly over the top of the plate, and it can bring the carpus with it. Particularly the lunate will collapse over the volar surface of the distal radius, and that can cause problems. So there's many different techniques to use volar plates, but in general, you want to reduce the fracture. And a good way to approach these is the extended FCR approach. There's many good videos online on how to do this, and this can give you a very good proximal and distal exposure of the entire distal radius. So after you reduce these, one way to fix these is to place this proximal oblong hole, and that gives you some play if you need to adjust the plate proximally or distally. And then you want to get K-wires through your distal guides. You want to check your reduction. You want to perform your intermediate column fixation first, and once you lock that in, then you can form your radial column distal fixation. And then you can finish your proximal fixation. And then you always want to assess for a volar rim fragment, and you always want to assess the DRUJ after fixing these. Like I said, there's many different ways to fix these, but this is one commonly performed technique or method. This is a nice schematic of this volar plate, and essentially, if you can understand the details of this plate, it'll really help you understand how these work to fixate these fractures. And there's a couple different views here that are helpful to really understand how these distal screws and pegs are designed. And in this view here, you can see the radial column screws are supporting the subchondral surface of the radial column, or the scaphoid fossa. And these four screws, these four pegs, subchondral pegs, are supporting the lunate fossa. And this is just a couple of views when you're starting out to really understand what you're looking for and some of the details of this plate. And initially, when you get your K-wires in there for your preliminary reduction, the K-wire goes through this hole in a standard plate, and that's on the proximal portion of the intermediate column segment of this plate. And you'll see with this K-wire and the remaining pegs, these extend distally to the dorsal portion of the distal radius. So it's important to understand when you're placing these, typically these screws or pegs, these subchondral pegs, are shorter than the distal pegs or locking holes of this intermediate column plate. And you can see that here. This is that distal hole of that intermediate column. And this is essentially supporting the subchondral bone of the central portion of the lunate fossa, the central and the volar, whereas these proximal portion of this plate is supporting more of the dorsal and distal portion of this distal radius. So these pegs are typically a little bit shorter. And in terms of your placement, you want these pegs essentially right under the subchondral surface. You don't want them too far, or you'll be in the joint, and you don't want them too proximal, or else the distal radius fragment can actually collapse. And then here are the radiostyloid. Here's the radiostyloid portion of this plate, and here's the pin that goes through this guide right here, and you want it directed directly at the radiostyloid. And then you want to fill your remaining three subchondral pegs, which are in line here to support the scaphoid fossa, and you can see that right here. So this plate was designed very specifically, and every single peg or screw in this plate was designed for a purpose. So it's important to use all the holes, especially distally. There's different options. Proximally, there's 3-hole and there's 4-hole. 4 holes commonly used just to give yourself an extra point of fixation if needed. So something that I've talked about it a couple times, but you always want to think about this volar rim fragment, and this is a nice CT scan here that shows its significance. If you can be a very small fragment, but essentially the lunate is sitting on this fragment, and if it displaces, so can the remainder of your carpus. So if you see this, you want to provide some form of fixation. This hook plate is an option. These are fractures you might want to consider a dorsal spanning plate or some other form of fixation to prevent late collapse of this. And you can also appreciate in this CT scan, if you put a volar plate right here and you fix the subchondral bone, this piece can be so small it can still escape over the volar rim of the distal radius plate, and you can have a problem even though you thought you might have had a good fixation. So I want to discuss when to use a dorsal spanning plate, and here are a couple indications. Severe articular comminution with a metadiaphyseal fracture and a high energy injury, very distal fractures like we discussed, associated radiocarpal instability, and then polytrauma with the need for immediate weight bearing. And now I just want to talk about a couple mistakes or a couple things to look for with volar plating. And the first is radial translation of the distal fragment. The brachioradialis inserts onto the radiostyloid, and there's also radial pull from the first dorsal compartment. And in the extended FCR approach, you do a step lengthening of the brachioradialis to release the pull of the brachioradialis. And there's also the option to release the first dorsal compartment, which runs right over the top of the radiostyloid. And this will prevent some of the radial translation. The other thing you want to make sure you do is when you do your exposure, you want to actually be able to see the ulnar border. You want to actually see this reduction before you do your definitive fixation, and that will prevent this radial translation. And then in the right fracture type, you might consider a radial column plate if there's a styloid fracture. So we talked about this, but another thing to assess, if your plate is not distal enough, in the OR, you can do your reduction, get your plate on there, and you can see this looks like good placement of your distal pegs and screws, and they need to be immediately subchondral. And in this particular patient, there was not enough subchondral support, and this fragment actually collapsed dorsal, and you can see that by the lift off of this distal radius plate and the volar rim of the distal radius. So you want to make sure these pegs are immediately subchondral. And then this is that previous picture I showed, but there's another point I want to bring up, which is plate liftoff. So you can do a reduction on these and place your distal radius plate, and for some reason you can't always figure out why you have this gap that you see between the distal radius and the plate, and there's a couple different reasons for that. One of the reasons is you're not distal enough, like we discussed, and another reason is if you actually put this plate on a distal radius bone model and you shift it distal, proximal, ulnar, and radial, you'll see based on variations of anatomy, if your plate is shifted too far ulnar, your radial styloid component can actually lift off, and vice versa. If you shift your plate radial and it's too far radial, your ulnar column portion of the plate can actually lift off. So that's something you want to think about if in the OR and you're doing your reduction, outside of just not reducing the fracture enough with, whatever reduction maneuver you're using. These are some things you might want to think about if you have a slight step off between the plate and the actual distal portion of the distal radius. Another thing that will come up occasionally is you'll actually see a gap, not at the distal portion of plate, but just proximal to that. And This is based on the actual plate design and variations in patient anatomy. And the most important thing is to make sure there's contact proximally and distally. And based on the exact design of this plate and certain patients' anatomy, occasionally you'll have a millimeter between this central portion, and that's actually okay. That is just based on certain limitations of plate design and patient anatomy. So then, like we talked about, you don't want your plate too distal. You can cause tendon rupture, and then one of the worst complications would be intra-articular screws. And this is a CT scan with intra-articular screws and an intraoperative view actually showing intra-articular screws. And one way to prevent this, along with many ways, is to do a 15 to 20 degree elevated lateral view X-ray, and that will allow you to see right down the radiocarpal joint and help you see. And then you also want to perform range of motion after your fixation and make sure you don't feel any crepitance or catching, or make sure there's no screws actually in the joint. So another classification that's important to understand in regards to distal radius plates and volar plates and tendon ruptures, the SUM classification. And in this, there's 3 grades, grade 0, 1, and 2. And if you draw a line longitudinally with the volar rim of the distal radius, and then you look at the actual most projected portion of your distal radius plate, if the plate is dorsal to this line, that is a grade 0. If the plate goes over this line, that is a grade 1. And if the plate projects past this line on the volar rim of the distal radius, that is grade 2. And these grade 2s have a significantly higher risk of flexor tendon rupture, particularly your FPL and your FDP. So if you have a fracture that you just have to put the plate distal just to get good subchondral support, say it's a very distal fracture, you don't want to lose this volar rim fragment. In the post-op period, you want to keep an eye on any symptoms of tendon irritation, particularly FPL and FDP. Here are my references. Thank you very much.